you're going to be very excited to hear our presentations. As I mentioned before, we have several panels today that look at different aspects of care. But I want to start with a great overview. And so our morning panel, they'll all be speaking from the podium. And so they're going to also introduce themselves. So let's get started.
Okay. Good morning, everyone. I think you can hear me, right? Excellent. I can project. Okay, is that better? Okay, positioning. All right, there we go. Thank you. Okay, well, so my name is Amy Kelly. I'm the Deputy Director of the National Institute on Aging, and I am delighted to kick off this session, but I also had a really difficult charge, which is to give kind of an overview of
Let's hold on for just one second. I apologize. We're having a technical difficulty. We want to make sure that everything's being projected to our virtual audience too. Sorry about that.
No.
Okay, so we're ready to resume.
Okay, excellent. So I am going to move through some descriptive slides with some speed, but all the citations are on there. The slides will be shared. If there's something you are interested in and you'd like more depth, please just return to those later. First, I wanted to start with a little bit of a background on the next slide. I often start talks with this photograph. This is my grandfather and his sister. I had several really important older adults in my life growing up, many of whom aged well into their 90s, a few of whom suffered with dementia as well as other chronic conditions. And that experience really colored what I took away from my medical training. I did internal medicine at Cornell, stayed on for a geriatrics fellowship. I worked briefly at UCLA on getting my research career launched, and then came back to Mount Sinai in New York. And just to reflect a little bit on Adrian's comments about primary care, in my geriatrics practice at all three of those places, we also had pretty substantial philanthropic support. So one of the things that drew me to geriatrics was, most of the chronic condition algorithms go out the window because you're working with a patient who has 8 conditions and a family and a living situation and all of those factors that are really challenging to put into a comprehensive care plan that's driven by the person's preferences. And that's what I loved. But in those practices, I had the extra time. I had the luxury of 20 minutes or even 30 minutes to spend with a patient and to really put the whole picture together. So I'm going to start with just a couple of, on the next slide, and then maybe even the one after that, just a couple of cross-cutting data slides. This one you saw a version of from Arlene earlier in her talk. This is an updated one. Thank you to Sherry Ling for the data. You can see that circled bar, the Alzheimer's and dementia group, it is a rare person who develops dementia and has no other medical conditions. And in fact, they may have been living with multiple conditions, 4 or 5 or more, for many, many years before dementia appears. This slide doesn't really tell us where in the course of dementia these people are. Again, it's really just a cross-section from their Medicare claims data. If you go to the next slide, you can see a different attempt to look at the population with serious illness. So in addition to being a geriatrician, I'm a palliative care physician as well. And one of the things that field has struggled with recently is identifying the appropriate population that should be served by palliative care or offered supportive services. So this study took one attempt, again, cross-sectional, to look at people who either had dementia or required assistance in their activities of daily living or had another advanced medical condition, so metastatic cancer or advanced heart failure. And what you can see in this slide is that there is tremendous overlap in the dementia population with these other arenas. And in fact, 70% of people with dementia have another condition or illness that would qualify them as being seriously ill on top of their dementia. And on the next slide, you can see again just a little bit of a taste of how this plays out in their healthcare. in the bars along the bottom, you can see the different combinations that were shown on that last slide. So dementia only is in blue, people who have dementia with another advanced condition, again, like heart failure or advanced cancer. Those who have dementia plus require assistance with their activities of daily living in purple, or in fact, all three in black. And really the takeaway message here is these folks show up in the hospital very frequently. Some are near the end of life. They are marked there in that second chart as dying within the following year, but really you'll notice most of them are not. So these are people who are ending up in the hospital coping with multiple conditions, some of them quite advanced, and are living in that state for quite some time. You can flip forward. So this next slide, I'm going to share with you this and a few others that are really just what I would call data signals that things aren't working out so well, that our systems and our services are not addressing the needs of the population. So again, here you can see the frequency of emergency department visits for people with Alzheimer's disease and related dementia. 28%. It's huge. So this is a population that is arriving in the emergency room quite frequently. On the next slide, you can see the experience of people living with dementia and Medicare Advantage. I think, Sherry, you can correct me if I'm wrong, I think we've tipped the 50% mark on Medicare beneficiaries being enrolled in a managed Medicare Advantage plan. So just to orient you on this slide, on the left and then the right, you see a split by what's called non-dual or dual. So we have people on the left have Medicare. The people on the right, the duals, have Medicare and Medicaid. And then we further break out both groups into people who have dementia and those who do not. And what I want you to notice here is when you compare people with dementia to those with not, they are disenrolling. They are dropping out of Medicare Advantage at vastly higher rates than people who do not have dementia. The programs are not built for them. They're not working for them. They're choosing to disenroll, and they're coming back into traditional Medicare, which not only has implications for that human being and the disruption of their services and the lack of meeting their care needs, but it has a tremendous impact on the Medicare program as well, and the costs of that program. So again, you could dive into more details here if you are interested. On the next slide, another program that is near and dear to my heart is the hospice program. And sadly, this demonstrates, the data here, gives us some red flags of how hospice is not working well for people with dementia. So as many of you may know, the hospice benefit is designed for people who are within the last 6 months of life. It provides support for caregivers a little bit. It provides symptom management, home visits, respite care. Many people enrolled in hospice have dementia. In fact, in this study, we found that a full third of people who were admitted to hospice for a different reason also had comorbid dementia. The people who have dementia who are in hospice are much more likely to stay longer than 6 months and are disenrolled or often kicked out, in essence, of the hospice program. And it's quite a significant disruption to that person's care, to their family. It creates a lot of mixed messages about what is happening in the long-term progression of their illness. And you can see other markers here of sort of the inadequate fit of the hospice care model to the needs of people and their families in the context of dementia. So moving forward, again, I wanted to shift a little bit to talk about care partners and families in particular, and we can go to the next slide. Again, just a snapshot here. We have a look back period of about 10 years. This is based on survey data, so families who have reported who is providing caregiving hours, non-paid caregiving hours over the course of illness. You can see at the tail end of those both charts, those without dementia who are on the right, those with dementia on the left. At the end of life, that last year, lots of people are providing care for their family members. That is extremely common and is a difficult period. On the left, though, you can see the families that are coping with dementia have curves of caregiver support that is unpaid for, that extends well out 5, 8, 10 years even prior to that person's death. You can also see that the adult children are in the orange line. A substantial portion of that caregiving effort is being provided by adult children who often are caring for their younger kids. They have jobs. There's all sorts of other demands on that group at the same time. And as you can see, that need extends over many, many years. On the next slide, I also recognize that this group is very well aware that the work of a care partner is 24 hours a day, 7 days a week, all year round, and it is really challenging. We find from survey data that care partners report tremendous amount of stress in coordinating healthcare, navigating the healthcare system, and trying to find support that they need to be an adequate and effective caregiver. And on the next slide, you can also see that in very real ways, this has a negative impact on the health and well-being of the caregiver themselves. This particular study is not limited to caregivers who are working with a family member with dementia, but I think you can appreciate the impact in terms of stress, depressive symptoms, physical health, mental health that is the difference between those who are caregivers and those who are not. The next slide also gets to the cumulative financial impact. This was actually a little bit of research that was from my group. We were trying to get past the idea of studying healthcare costs only through one lens. So often we'll see studies that focus on the Medicare impact or the out-of-pocket costs, and we really worked with a variety of sources at the individual level to bring together the entire picture. So you can see here we've monetized time, so that unpaid caregiving time is in the blue. We calculated out-of-pocket spending over that period, the contribution from Medicaid, Medicare, perhaps other sources of insurance. And you can see just the dramatic difference in the cumulative cost of care between those with dementia and those without. And then if you look at the blue and red, the top chunk of that accumulated cost, that is all borne by the patient and their family. And the next slide. So just to shift gears again, tell you a little bit about where NIA is active in this space. We have a substantial research portfolio, including, but not limited to, the work that focuses on dementia care and care coordination, so quality, effectiveness, assessing different models of care. We also fund a range of studies of the economic impact, like what I just showed you, but really thinking about that from the lens of the individual, of the family, and of society overall. And then finally, research that is aimed at developing and evaluating training or other caregiver resources for people coping with dementia. And on the next slide, please. So a few years back, 2018, NIH also commissioned a two-part study led by some of our colleagues. So AHRQ did a systematic evidence review for us, and then NASM developed a comprehensive report, and really came away with the key messages that most of the research out there at that point in time focusing on caregiving interventions were too small to be pulled together. They had small sample sizes, were pilots, very focused populations, or had other risk of bias. But the recommendations were quite clear that there should be more effort put towards implementing and studying the outcomes of collaborative care models and of resources for enhancing Alzheimer's caregiver health. So again, a couple of the issues I already showed you some of the data on, really needing this additional research. So on the next slide, I think it may have already been mentioned today, but the guide model that CMS has announced last year gives us a new voluntary care model. It is pulls from a range of evidence that came out of NIA-funded studies, but puts together this comprehensive program that is designed to improve the quality of life for people with dementia, to reduce the strain for their unpaid caregivers and their family, and ideally enable these folks to live in their homes, in their communities, and to maintain a high quality of life through the course of their illness. On the next slide, before leaving the guide model, I should just say that one of the things that NIA is interested in is thinking about how we can study the impact of guide and other comprehensive care models and see if we have the evidence base to further advance those types of programs. A couple of other studies I just wanted to share very briefly. I showed you some slides about how frequently people with dementia end up in the emergency department. And so this is a study that leverages that fact of the current care experience and tries to advance care delivery and better quality of care for people with dementia and their care partners who do end up in the emergency room. So this is a three-pronged intervention comparing a changed emergency department experience. One is a nurse-led telephone-based intervention. The other is a transitional care program that is provided by paramedics. Again, trying to think of creative ways to leverage some of our other partners beyond just physician services and get care to people where they need it, especially in these moments of crises. On the next slide, you have probably heard a little bit about the Impact Collaboratory in our prior NIA updates, but this is, again, a collaboratory focused on pragmatic trials. What can we enroll in the current healthcare landscape and study now? And a big part of it has actually been a long-term care data cooperative, and we're hopefully just getting started with all that we can learn from this group of nursing homes. It's more than 2,000 facilities currently involved across the United States. So again, really beginning to collect a lot more evidence in that space. And that is the end of my comments. It's a whirlwind tour of what I hope sets the stage for the next set of presentations. And as with all of you, I look forward to hearing from my colleagues.
Thank you very much.
Thank you, Amy, and everyone. Good morning. My name is Roberta Cruz. And okay, Amy, I think you did a wonderful job setting things up. I also appreciate, Adrian, your transition from the federal updates. I have to acknowledge that it's interesting to hear all of this and to be going back to the journey. And I will say, just to give context, this is my mom. Her name is Zenaida Cruz. She went by Zenny, and she also recently passed 6 weeks ago. So it's very fresh. I'm honored to be here. I'm honored to be part of this council to share and to share my perspective, to share our experiences as a family, to acknowledge the important work that all of you are doing in the different sectors and the different capacities that you're representing and contributing. So this is pretty normal for me that's here, so just know that that's part of me, who I am. So to give you some context, this is my mom. I'm the granddaughter of Remedios Kimson. I'm the daughter of Zenaida Hugh Cruz, and I'm the mother of Eva Cruz and Gustavo Cruz. our journey, my journey as a caregiver began in the end of March of 2015. And what I'm going to do is I'm going to take you through our journey interfacing with the healthcare system through photos and through story. And I think something really important to acknowledge for me, for all of you to know, is that one person, one caregiver cannot do this alone. As we've already heard, it is a lot to navigate. And so part of my share is to also honor what it has taken and who has been there with me to do this and to care for my mom. Okay, next. Oh, I have the control. Okay, no disclosures. So in this photo, the first people that I want to introduce you to, you've already met my mom. At the time, my son, he goes by Gus, he was 1.5. And so already my caregiving journey, as acknowledged by Amy, my caregiving journey coincided with my motherhood experience. This photo of my son playing with the rolling cart, that is us in the clinic, the clinic with my mom's primary care provider in Richmond, up in the Bay Area, West Coast. And the gentleman on the side, that's my husband. His name is George, and he has been my partner in this journey. At the time of our start with caregiving for my mom, he was actually in his internship year. As many of you physicians know, it's a difficult time. So just with this particular slide, the beginning, we came, like I think a lot of caregiving journeys begin, there's a moment of emergency, right? And this particular image, I mean, it was me trying to capture this moment, but it was also a crazy time as we had to show up. It was my son, my husband, my father, myself, and then my mom. So imagine a room, and 5 of us show up. And the reason why is because her nurse practitioner was kind of in denial, did not think we needed to screen her. We were in the process of making the transition of moving her from my family home to then live with us in North Carolina. And we knew that we needed to leave the state with MRI or get as much done as possible so that our process of transitioning her care and setting up her primary care in another state would be smoother. The only reason why I knew that is because my husband came with knowledge of the healthcare system, having done a geriatric rotation, having been in hospitals, having cared for and learned from his attendings. Throughout this journey, the other consideration to share as we're talking about interfacing with the healthcare system is that as an adult child of immigrants from the Philippines, my navigating systems was very different than the way that my husband navigated systems. Meaning to say that, similar to my mom, when we would show up to doctors' offices, when she would go to her nurse practitioner appointments, it's very much the authority tells you what needs to happen or what's happening, taking place, and you listen, you take it, you say yes. Even if you may not understand fully, you say, yeah, okay, and you go on. And maybe you talk about it later. So what's critical about this photo and this time is that without the partnership and without the knowledge and lived experience and professional experience of my husband, which I'm I think I'm just very lucky that that happened to be our foundation. Our journey would have been very different, because with this, and I have to acknowledge him also being a Black male, being in a system where he has had to advocate for and had to voice and be very clear about what our priorities were for each visit. It allowed us to really advocate for my mom. So I think that's primarily what I wanted to share with this slide. And so, actually, so this picture in the clinic is in Richmond, California, Northern California, Bay Area. This was actually when we arrived from the plane in North Carolina, and transitioning to now being in North Carolina and deciding, after having a very difficult kind of transition of trying to get my mom's stuff in order for then moving out of state, having a 1.5-year-old child, and literally my son would be with us wherever we went. It was the three of us. I knew at that time, being new to, well, I had my healthcare set up, but, navigating a system for my mom, we had one visit where we went to see a geriatric specialist. And even in that visit, something as small as parking, something as small as accessing where the physical appointment takes place, that can be an obstacle, and it is tiring, right? And we're talking about our folks who are experiencing dementias. Like it can be confusing, it can be disorienting. So we made the decision, again, against my growing up. My mom, as an immigrant, was always like, don't pay for things that you don't need to pay for. It's like, you're always saving, you can do that, you can make that, you don't need that. And in this situation, as a new mom, my husband is in his training, neither one of us are salaried, like things are just messy. We made the decision to explore and learn about what concierge care. We were living in Durham. My husband's training was taking place at UNC, but we had established a little network in Durham at the time. And so that's why we were there. And so we came upon Duke Integrative Medicine. We decided that it was an investment for us as a family to, I think it was $150 a month, right? It's like a membership where we would pay that. And I should say that my mom, she did have Medicare, but it was worth it for us. It was worth it for me as the caregiver, as a mother, as a young mother, as a partner to a student, physician in training, to have the accessibility. And honestly, it felt very luxurious, right? Where there was immediate response if we did need to call our primary care provider, who was a physician. The physical, this is the entryway to the lobby. And this picture here with my son with this truck, this is the labyrinth, which was on the property. After appointments with my mom's new primary care provider, we would take walks and we would just have time to ground ourselves and to process. And I think just to breathe a little bit with oftentimes the overwhelming information of each appointment. And so it was not an easy decision, and meaning like the values that I grew up with. But again, it was always in constant conversation with my partner, with my husband, about what we as a family needed to do to make this work for all of us. Because while my mom's care was the priority, we also had to think about my son. We also had to think about our health. And I consider us in some ways very privileged that we happen to be in this urban setting where there's a lot of resources. And then at the same time, it was a very challenging situation for us to navigate, as we don't have generational wealth. We do not have a network of family that we were able to call up and like lean on through any of this. And so that's how we arrived at concierge care. Trying to think if I'm forgetting something else here. I'll go ahead and go to the next slide. So, and I'm going through this somewhat quickly, and just imagine that we were in Durham from 2015 until 2018. So there was a lot of movement. So if you're tracking, right? So we went from Bay Area, Richmond, California, San Pablo, cross country to North Carolina. While we were in North Carolina, Duke Integrative, we were in Durham. She's not in this picture, but we decided to grow our family in the unknown territory of caregiving. We still decided that it was important for us to continue living our lives. And so my daughter was born in 2016. Her name is Eva. And these photos are actually sharing with you the point at which we decided that we needed to move my mother to a memory care community. Again, throughout our journey, priority was, yes, my mom's care, but then also it was always balancing what we needed as a family. And in this time, my daughter was 2 months old, and my husband was still in his training. And by this time, we needed a break. So the interactions with the healthcare system in this setting, while she was at a memory care community, is that, you know, they had folks in house, but in this is actually a dental visit, and it was difficult. As you all know, it's costly to have a loved one in a memory care facility. But again, at this point in our journey, it was important. It was one of those moments in my marriage with my husband where he said, "It's time for a break." And we managed kind of the overseeing and the care by making sure that myself or my brother or different family members were visiting her at least once a month, and that was hard. She was very active, and she was what do they call it? An exit seeker. And so the third time that we received the call, that she made it out, is when we decided that we needed to move her back to live with us. So I'm gonna fast forward. The final stage, she returned to us by the time we were in Chapel Hill. We set her up again with Duke Integrative. It was a seamless return, which was amazing. The same physicians, it was great. And then this actually, Chula Vista is the city just south of San Diego. We moved to San Diego, so multiple cross country, because Sacramento's back in California. And these are all driven by our family's needs, because what we needed was important to be able to take care of her and make decisions for her. The final stage took place back in San Diego as my husband did a fellowship that took us back to San Diego. And we were able to actually have a positive experience with hospice, but I will say, I was reminded as someone was talking about hospice, we had an initial, we were initially approved to join hospice when my mom declined. She was showing signs of decline in the winter of 2019. And that's when, again, my husband was like, we need help. And I think now is the time to check and see if she qualifies. She qualified for one reason or the, well, And at the time, I should say, we were working with a caregiver. We met a caregiver off of care.com. And she was our third person that we met. Her name is Marisol. She is like a sister to me because she was then there with us until the end. I guess what I want to finish with is that she was on hospice for 4 years. Each time that she was reviewed, she qualified in January of 2020. As we all know, the pandemic hit. July of 2020 is when she was completely bedridden. And then she was bedridden until she passed March 13 of 24. The hospice team was like family. And could not have done this without that support and without Marisol. And I'm just trying to think anything else. I know I'm up on time, but this is my son, my daughter, in the hospital bed in the home of Marisol. And I'm happy to speak more later when there's time. Thank you. Salamat is how you say thank you in Tagalog, and gracias.
Thank you for sharing your experience. It's always important that we be grounded and understand who are we talking about, who we taking care of here. So thank you very much.
Hi, everybody. Can you hear me well in the back? I'm Sue Borson. I am listed as representing the Bold Center on Early Detection of Dementia. I'm actually representing a different point of view, but one that's entirely consistent with the work that we're doing in the Bold Center. So my topic is not early detection of dementia. Thank you very much, Lisa, for those beautiful slides describing what we actually are doing. And I want to also thank Dr. Bierman for talking about a way of collecting data that's entirely consistent with what I'm going to be talking about now, I hope. So my talk is about no crisis care. This is a way of thinking about what dementia care really ought to be. I was sad to hear Roberta talk about the journey started with a crisis, but that is the way it usually starts. I would love one day to see the journey not start with a crisis. And someone asked me, I think it was Adrian, to mention that I invented the mini-cog, which many people do know about, and which was developed expressly for the purpose of detecting dementia before a crisis. Does it always work? Certainly not, but it is a step in the direction. So my own background is in geriatric psychiatry, but I have what I consider to be the heart of a primary care doc. That's where I started. I started in a little clinic as a medical student serving farm workers in Delano, California. Wanted to be a primary care doc, but at the time you had to become a specialist. So I went to internal medicine, and then I went to geri psych, and you can't get more specialized than geri psych. But now I'm back in primary care as professor of clinical family medicine at USC in Southern California. So the roots of dementia care, we've seen a tree before, and they are medical and healthcare activities, social and community services, and dyadic engagement, coaching, and support. So we've got these three sectors that we're always paying attention to when we're starting to think seriously about dementia care. So here, I don't expect you to read this slide, but I want to mention that ASPE RTI has put together 14 processes of care that are considered essential in providing good dementia care. They're listed on the left-hand side of the slide. I want you to take a look, though, at the right-hand side of the slide, the estimated uptake of these processes of care. Now, many of them we really don't know anything about the uptake because it hasn't been measured, but some of them we do. The greatest uptake really for the first process, which is to detect cognitive impairment. So that is represented here by the annual wellness visit, one of a series of really innovations that CMS has brought to bear to enable high-quality dementia care if we did it. So I want to pause on that for a moment, that CMS has delivered to us tools for very high-quality dementia care. But the first was the annual wellness visit requiring detection of any existing cognitive impairment, only 30% uptake as of 2023. That's way better than it was, but it's still falling far short. If you look at what we do know about the uptake of the other benefits, some of them CMS benefits like cognitive assessment and care planning code, less than 3% of eligible people have had such a visit. So we can enable good dementia care. We'll say we'll pay for it, but the problem is we're not actually delivering on that promise. Okay, so I want to talk about shrinking our objectives from 14 processes to a set of principles and goals. Our overarching goal has to be a vision. Similar to the vision of the Napa Council when it was first founded, the idea was we'd have a cure for Alzheimer's disease by 2025. Well, we don't have that. We're not going to have that. But it was a good vision, wasn't it? It drove a lot of very, very productive, important discovery research and therapeutic research. I want to propose a similar big vision, and that's the no crisis care vision. Okay? If we're going to be able to consolidate dementia-capable care systems, we have to follow a set of core principles, not just a laundry list of important processes, but what the core principles are and what meaningful outcomes we should be seeking. I want to remind you all of what you know, which is that dementias are generally, not always as we well know, but generally conditions of old people. And the problems that old people with dementia have are other problems of old people, like failing heart muscles, failing kidneys, failing musculature, failing joints. And these are all part of the aging, all conditioned by the aging process. So we have to start with a kind of realism about what we're dealing with. If we are to do this, what are the principles that I think we should follow? The first is detect it early. And that means before a crisis. It doesn't mean when there's a biomarker positive blood test in someone who is asymptomatic. Then center continuity of care. Centering continuity of care is a principle of primary care. Adrian talked about the challenges in primary care today. They couldn't be more problematic. But continuity of care with a clinical team, with a clinician, is the foundation of effective chronic care, period. Then embrace complexity because it's here to stay. Don't be afraid of complexity. This is something that makes it fun, and it's why I keep working. It's because complexity is such an important challenge. And then manage risk, and that's make no crisis a goal of care. Let's avoid crises. Okay, so how are we doing? This slide didn't transmit very well, unfortunately. I'll just tell you what it's all about. Basically, I show this slide. It's from a study we did at Kaiser, Southern California, looking at where was the first dementia diagnosis made. Was it made in the outpatient setting or in the inpatient setting? And if it were in the outpatient setting, who made it? Was it primary care, geriatrics, neurology, psychiatry? Who made it? I'll focus your attention on the hospital diagnosed group. This is about 45% of all first diagnoses of dementia at Kaiser Southern California were made in the hospital in a person who was over 80 and had high levels of comorbidity, and Elixhauser comorbidity index of 8.7. That's a lot of diseases. First diagnosis of dementia in the hospital. Now, we know some of that was only delirium, but we also know that delirium is tightly woven together with chronic brain failure, otherwise known as dementia. Okay. So, well, what about after diagnosis? What do we know about that? So if too many people are diagnosed in the hospital, well, what are we doing once the diagnosis is made? Well, we're not doing, I've already shown you the numbers about implementation of CMS benefits. They are very low. Here, though, I'm illustrating high continuity of care and what that means. It means that you have fewer crises. Now here, we can talk about what crisis is. There are lots of kinds of crises. There are certainly family crises. Families fall apart under the stress of dementia care. We know the statistics about caregiver health and well-being, and I will not repeat those for you, but many of us have lived those and continue to live those in different ways. But one of the ways that we measure continuity of care and crisis is a person being cared for by the same doctor or the same clinic or the same group of people over time, or do they travel between doctors a lot? That's about continuity of care. We measure crisis most often in terms of acute care utilization in healthcare systems. That's emergency room visits and hospital visits. Why? Why do we define crisis in this way? Well, first, because these are crises. An emergency room visit and a hospitalization, those are crises for someone with dementia and for their families. But we also define them as crises because they cost us money. And we can measure them easily because they're tied to our financing system. So here, this is really just about looking at crises defined by acute care, unplanned hospitalizations, and acute emergency room visits. And there are two really important studies that showed that if you provide high continuity of care for patients with dementia, their acute care utilization is less. The most impressive findings really came from a study in Canada. That's the one on the right, showing that you can prevent one emergency department visit in one patient with dementia if you provide continuous care for 29 patients. That should be manageable. That should really be manageable in our primary care systems. Okay, so we do a lot of talking about primary care and what primary care needs. We've also shown many times over that primary care doctors are not confident in the way they understand dementia, diagnose dementia, care for patients with dementia. All of that is true. I believe that as specialists, we have kind of loaded an extra burden on primary care, expecting them to do things that they are not comfortable with. I'll tell you, it probably took me 10 years of dealing with patients who had, almost all of whom had dementia, before I felt I understood the brain. And this was also studying the brain while I was caring for patients. It takes a long time. I look around and I see these brains in the room, and I realize that they're all protected by our faces. I can't see your brain, but I can understand a lot about your brain now because I've spent a lot of time working on it. This is not what primary care docs do, and it's not what they need to do. So what is it that they need to do and want to do? They need to be able to provide continuous care. They need to be able to have the resources to provide the care that they know should be given, and they need a way to think about being valued. So here is a study of primary care clinicians talking about what they do, what they value, and how relationship in clinical care matters for dementia particularly. So this was, you're not seeing the citations here, and I don't know why they're not showing up on the slides, but they're not there. So this is work that was led by Alyssa Bernstein-Seidman at UC San Francisco. She is a medical anthropologist, and in the last year or so, she and I have developed a project together to extend the work she'd already done with primary care. Now we're interviewing primary care doctors about what they value. What are your values when it comes to dementia care? What do you consider a success? What's a failure? And we're learning a lot about this. But among the most important things that we're learning is that primary care docs have exactly the right values for care of dementia patients. They can use the benefits of specialty consultation, but they are the ones who care for the patient. As we've heard many times, I care for the whole patient. The specialist cares for the brain. That's a brain doctor. I'm the person doctor. Okay. The other most important thing that we've been learning about from them is that health systems do not honor the values that primary care doctors have. And that translates to not valuing what primary care doctors do, and it translates into not paying them for what they do, or ensuring that what we know about high quality care can actually pragmatically be delivered to patients on a wide scale. So what does this all come to? So this is the 6 domains of health, and this is my current way of thinking about what we should be aiming for. If we want to achieve no crisis care, we can't achieve it. We can work toward it. Why can't we achieve no crisis care? It's because people with dementia are old and things happen. And those of us who are old, my singing teacher says, don't ever say you're old. Okay, well, I just said it. Too bad. So things are going to happen. The goal of no crisis care isn't really more realistic than a cure for Alzheimer's by 2025, but it's a moonshot in both instances. So 6 domains of health is a teachable framework for whole person care. So this is caring for the whole person in the context of their lives. This is not the same as the concept of person-centered, which has to do with what you want in your care. This is about seeing the whole person in the whole context and delivering care that meets the needs that arise within each one. Why are there 6? Well, it started with 4 in 2012, and the 4 were the first 4: cognitive health, emotional and behavioral health, physical health and function and treatment, and care partner capacity and needs. That was what I learned from taking care of hundreds of people with dementia and their families, those 4. Then I began to think about, well, gosh, health services are really important, and maybe there's a health system variable in there too, something about care delivery framework, and a whole lot about unmet social needs, health-related social needs. So now it's 6 domains of health, starting with cognition and moving through emotional and behavioral, through physical and medical, through care partner, through health-related social needs, and the full organization of the way we deliver care, both within and across systems, healthcare to community care. It is a teachable framework, and the teaching part of it is listed in these funny kind of shape: level 1, level 2, and level 3. Level 1 is problem detection. Detect a problem. Where is there a problem for this person in each domain? Some people will have a problem in only one. Early dementia, very often it's just cognition. Very mild, very early dementia, just cognition. But as people progress through the journey, more and more of these domains come into play. And so we want to be able to provide a way of detecting problems across the domains and developing a sense, who is this person in terms of their needs? The second is detailed assessment, just fancier evaluations in the same domains. And then level 3 is care management. This is a program that's currently in development as a RN dementia assessment and care training program that's being piloted with undergraduate nursing students and a very small group of RNs under the direction of Carolyn Clevenger. So 3 domains focus on the patient. And this is a study. You can take a look at this at your leisure if you're interested. This is an actual study of very complex people with dementia to learn, well, how did they score across these different domains of health. 3 focus on care, 3 on the patient, and 3 on care. So again, this is the same study. You can take a look at your leisure with the slides. It was interesting because these are complicated people defined by the fact that they had recently been in the hospital. They had dementia and they were recently hospitalized for a medical problem, unplanned admission. They come out behaviorally disturbed. The caregivers are stressed. Some of the caregivers are cognitively impaired. They come out with caregivers who don't know quite everything they need to know about caring for the patient at home, having received no training at the point of discharge. Okay, so there's the paper. And I want to thank all of my colleagues. There are very many, but my primary colleague in developing the 6 domains of health as a curriculum has been Tatiana Sadak, who is now Deputy Dean of Nursing at Yale. Thank you very much.
Thank you for giving us a setup of how we should look at the rest of the day. We are going to go into our second panel here. Just going to look at the perspectives from primary care, a memory clinic, and then some key tools about how primary care can do this. Thank you.
Good morning. I'm Monica Parker, and I'm a family physician, primary care physician, who spent the first quarter of my career, first third of my career delivering primary care in a rural setting. I moved from there to an academic-based geriatric practice at Emory University. And now I'm in my last chapter, I like to say. I direct educational outreach for the Goizueta Alzheimer's Disease Research Center, where we try to get people engaged, healthy people engaged in clinical research in Alzheimer's and related dementia. Those are my disclosures, and we'll move into the case study. Okay, case study number 1. And a lot of what I've heard this morning kind of plays out in some of the case studies that you're going to hear. And one of the things that I think is most important, consistent with the first person, the care that a person receives is maybe across several different clinical spaces, may also be across several states. So this is the study of Mrs. A.W. In 2009, I want you to pay attention to the timeline. 82-year-old African-American widow from Connecticut presented for concerns about her memory. She was having difficulty remembering things, but she had no problems managing her household or driving. Not reported anyway. Her husband's death was in 2001. She subsequently lost over 30 pounds. She attributed her weight loss to less entertaining and loss of appetite since her husband's death. She'd been taking medications for diabetes and hypertension and expressed no problems. While visiting her daughter, who lived in Georgia, she was found unresponsive by her sister, the patient's sister. When the EMTs were called, she was found to have a low glucose level of 30. EMTs administered glucose and fluids until she was back at her baseline. She refused to go to the emergency room and said, "I'll just stay home." The family arranged for her to see a primary care doctor as soon as it was possible. When she got to the doctor, these were her clinical presentations. Chronic illnesses. We talked about chronic illnesses being present in persons with dementia. She had high blood pressure. She had type 2 diabetes. She had hypercholesterol, and she had been somebody who'd been obese, but with her 30-pound weight loss, she no longer met that criteria. Her medications included metformin, which is a diabetes control medicine, amlodipine, antihypertensive medicine, aspirin, and glipizide, which is another anti-diabetes medication. She had no surgeries. She was a former teacher. She was health insured. She was independent for all ADLs. She'd met all of her preventive health care measures, looking for things that are, likely to cause a lot of drama in your life as you get older. She was up to date on all of her screening examinations. Family history significant for hypertension, diabetes. Mother and sister died after recurrent strokes and the onset of dementia. As a result of the studies that were done by the primary care doctor in Georgia, she did get an MRI and an MRA to look for stroke-like activities. They did find that she did have some brain shrinkage of her brain, if you will. She did undergo a carotid ultrasound that indicated that she did have some narrowing of the blood vessels supplying blood flow to her brain, putting her at risk for some stroke-like things. Her laboratories were as indicated. The most significant thing here is her diabetes. Her hemoglobin A1C was elevated at 9, which means that she doesn't have really good diabetes control. She went to see a neuropsychologist who does the cognitive testing. She was subjected to a memory screen at the time, the mini MMSE, the Folstein Mini Mental Status Exam. She got a 23 out of 30. Keep in mind, this is a master's degree teacher. She had a geriatric screen that indicated she didn't have any depression. Everything else is as you can read. She did have some impairments on her testing that showed she had problems with language, some executive function, some learning, some memory, but her daily functional abilities were intact and she was fine. So she was given a diagnosis of what they call mild cognitive impairment. So she had some deficits, but they didn't know what was really causing it, but they felt that she was okay. They thought that her vascular risk factors may have contributed to some of her cognitive deficits. Her family subsequently moved her from her home in Connecticut and brought her to Georgia. Note, from 2011 to 2013, she was doing fine in her home, at home with her daughter. She didn't have any further medical or neurologic evaluations. Her chronic illnesses were managed well without medications. Her home care had been managed by her family and paid caregivers, no behavioral symptoms. She was independent for most activities of daily living. In 2013, she became agitated, confused. She refused to eat. She fell and became somewhat lethargic. She was subsequently taken to the hospital, to the emergency room where she was evaluated. They found that she did have substance here is that it was diagnosed with a urinary tract infection. She was also diagnosed with problems with her diabetes. What's really happening with her here, she was admitted to the hospital with a number of things. They decided that our underlying condition was that she was suffering from a urinary tract infection. That's probably why she became a little difficult to manage. She also developed dehydration. And because she was having these difficulties, that's why she needed to be hospitalized. And she got fluid treatment for her dehydration. She got antibiotics for 3 days. She became a little agitated while she was in the hospital, but given that her clinical symptoms had stabilized, her family said, well, it's fine. Can we take her home? She went home. And she was diagnosed in the hospital with delirium and dementia. Delirium superimposed on her dementia. We're not moving. Oh, okay. She went home with her family and did fairly well until 2014, when she started wandering around and walking out of the house. And she didn't really know why she was doing what she was doing. An appointment was made for her to see a geriatric psychiatrist because, she is in Georgia now and she's got access to Emory. The psychiatrist saw her, put her on antidepressants and something to help with sleep, but they also recommended that she go to a structured adult day program. And she did pretty well until 2024. It's important to note that there's a 10-year history between getting her home life organized and putting things in perspective. In 2024, she died after being home with hospice. Her diagnosis on her death certificate was dementia. She did donate her brain and her spinal cord to our university for Alzheimer's research. And the pathology, I have to say, was mixed pathology. There weren't any genetics. How do I know all of this? She was my patient. She was my mother. And the important part here is, despite the fact that you have a family member who's involved with clinical care, doesn't guarantee that you're going to get the best care for either diagnostic care, longitudinal care, or even follow-up care. Case number 2, Mrs. P. I want you to appreciate that just about everybody you're going to hear about today has had access to clinical care. Think about the people who don't have it. Mrs. P is a 62-year-old corporate executive who retired in 2021 during the pandemic, highly capable. She and her husband plan to travel to other places. That's how she wanted to spend her retirement. She's able to drive, do most of her activities of daily living. Main problem with her, she had some high blood pressure, she had some cholesterol issues, but no real medical problems of significance. Significant family history was that both of her parents suffered from dementia. Each of them died in their 80s. In 2022, Ms. P traveled to Florida to participate in a bioHermes trial. If you're not familiar with that, it's just one of these studies where you can go and you can learn something about your memory. They give you the results of your MRI and your testing, and you can take that someplace else. But the reason she went was she was having some difficulty. She knew about this opportunity, but publicly she didn't want people to know that she was having trouble with her memory. As a part of that study, she did have a PET scan, which at the time was not publicly available, only through research. She did discover that she had an abnormal PET scan, and her memory testing or cognitive testing was also abnormal. And with that information, she did come to the research center at Emory for actual diagnostic evaluation. She never reported any of these findings to her primary care doctor, and she was subsequently diagnosed with Alzheimer's disease. She did enroll in some cognitive rehabilitation programs. She still maintains a lot of her functional activities. She is being treated, but her primary care physician wasn't aware of any of her deficits until she became involved in some of the rehabilitation studies that were a part of research. She still remains independent. Her spouse is now retired and is assuming full-time care for her and her daily activities, and her primary care physician is now aware of her actual diagnoses. Last case, Mrs. K, married to a corporate executive, works out daily, plays tennis, manages her activities of daily living, no major chronic illnesses. In 2021, she went to her primary care doctor for screening about memory problems because her husband said, well, she started to repeat herself and start to have some little things that he said, I noticed, but, I really wasn't sure about what it was. As a result of some of the things that he noticed, he did hire additional help to help supervise his wife's activities. A year later, she got progressively more unable to manage her activities. So the home help that was hiring for 2 to 4 hours a day now is being hired for up to 12 hours a day. Her primary care physician had not completed any further examination, didn't subject her to any particular workup. But he did refer her to a neurologist in a local hospital system that they were a part of. No medications were prescribed. They did order a brain MRI. They didn't do what we traditionally do in the academic setting. They just said, this is, she's got some kind of dementia going on and you just need to get more help. In 2023, because she had increasing cognitive and physical problems and deterioration, she was referred to our Alzheimer's Disease Research Center for a second opinion, and thought that maybe she would be eligible for research using different drug therapies. Well, of course, by the time she got her neurologic evaluation, it was determined that she wasn't a good candidate for any research studies. And at the time, she really wasn't a candidate for any particular interventional studies. At our center, she didn't get a PET scan. She got a repeat MRI. But at this stage, with an advanced stage of dementia with no further intervention indicated, they coordinated care or assisted her family with getting the kinds of social supports that she needed. The latter part of that social support did include enrollment in a hospice care program for in-home. And in 2024, she died, and she died at the age of 69. So I'm finished with that part of that presentation, but the other thing that I do need to make sure that you know about, you've just heard about 3 women who had access to health care, who had a rather circuitous route for getting the kinds of evaluation that they need. On Wednesdays, I work in a clinic. It's not a federally funded community care clinic, but it's faith-based community care clinic, which is heavily subsidized. And for my non-English speaking patients, we have a catchment hospital. I have to send them there for that. But when you don't speak English and you're having these challenges, it's really, really difficult to get an evaluation. And even though you have a, safety net hospital or system, that safety net system frequently does not pay for those services.
Thank you very much. That really does allow us to see the progression over time. So much time in our NAPA meetings, we talk about the diagnosis, early diagnosis, and biomarkers. But thank you for sharing those cases of a person's life over time. Thank you.
Great. Good afternoon, everybody. Can you hear me okay? I'm Esther O. I'm one of the geriatricians at Johns Hopkins University. I'm also the co-director of the Johns Hopkins Memory and Alzheimer's Treatment Center. Oh, okay. Is this okay? Can you hear me okay? All right. I'm going to do over. I'm Esther O. I'm one of the geriatricians at Johns Hopkins University. I'm also the co-director of the Johns Hopkins Memory and Alzheimer's Treatment Center. And thank you so much for having me here today. So I'd like to provide with you today some perspectives from our clinic, what our tertiary referral center does, but really presenting 3 different cases to highlight some of the more specialized care that we're hoping to provide, and hopefully that can be some of the models. So I have the honor of living and working in Maryland, which was, this is Alzheimer's Dementia Journal, the highest estimated prevalence of Alzheimer's disease in our country. So we are number 1. So as you can see that we have a fairly large memory clinic that I would like to describe to you, but the demand is great and the demand is growing. So right now we have 13 providers, soon to be 15 as of July, so in a couple, 2-3 months. So we have 5 geriatricians, 5 geriatric psychiatrists, 2 neurologists, and 2 faculty level nursing. So one's a nurse practitioner and 2 are PhD nurses. And so it's a very, very large practice. We probably have about 3,000 encounters every year, of which about 600 to 700 are new patients. Yet our wait list is so long that the next time I have an availability for a new patient or a follow-up patient is about November. And that's just not me. That's most of the providers in our clinic, even though we have so many providers in our clinic. And it's not just our memory clinic. Fortunately, we have a lot of other specialized clinics. So we have young-onset dementia clinic where they see frontal temporal dementia separately. We have a neurologist who see primary progressive aphasia, and that's a specialty. We have Parkinson's clinic, and we have atypical Parkinson's clinic. And yet, we still cannot meet the demand. The demand is so great. Who usually tend to refer to our clinic? A lot of primary care physicians, and sometimes even neurologists who tend to be generalists. So they often refer difficult cases, so diagnosis is very uncertain. Younger patients, as I had mentioned before, patients who are interested in research because we have a lot of research programs, and patients in moderate to advanced diseases whose family members seek out, is there a new cure for, our loved one? And some are just hoping to get some more additional information or education so that they can take better care of their, loved ones. We see a lot of patients, not just from Maryland, but from really our neighboring states and, fairly international referral as well, but many patients from Virginia, West Virginia, Pennsylvania, Washington, D.C., and so on. But we are not really who provide memory care across the nation. So here's a paper that we wrote, published in JAMDA in 2018. And it was really about what's called predominant provider. And so that was basically based on, who provides the greatest number of outpatient care for an individual patient. The data is a little bit older, and it's a Medicare data from 2012. But you can see that actually about 80% of our patients who have dementia in our country are taken care of by primary providers. So internal medicine physicians, family medicine doctors, a lot of nurse practitioners. In this table, we divide them by long-term care community, but really just to kind of highlight that, geriatricians like me really provide overall 2.6%. How about neurology? We think a lot of neurologists see a lot of dementia patients, actually not that much more. And psychiatry, also very few. So we really, 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 really need to be focused on providing education and really skill sets for our primary care providers who are out there providing frontline care for our patients with dementia. But I would also would like to say that especially for geriatrics and geriatric psychiatrists, we are seeing fewer and fewer doctors who are willing to go into this field because a lot of our patients are very complex. They take a long time. And so just really, that's another area that we really need to, I think, pay attention. I want to just kind of go into 3 of the cases that I have today. So these are patients that, were seen in my clinic, fairly recently, actually. The first is a gentleman who's 71 years old. He came with his wife from a neighboring state, was diagnosed with mild cognitive impairment by his primary care provider. And the provider did, MMSC at one time, MoCA or Montreal Cognitive Assessment, some basic blood work, but surprisingly, there was no imaging, no CT or, a brain MRI. Although this person who was diagnosed with mild cognitive impairment was already taking medications for early stage Alzheimer's disease and medication for moderate to severe stage Alzheimer's disease, but no brain scan at baseline and just diagnosis of mild cognitive impairment, which by definition is you're maybe 1 to 2 standard deviations off your cognitive dysfunction off from the norm, but have minimal functional loss. So just to highlight a few things in this case, one is that we are seeing more and more patients who are in this stage because there's a heightened awareness of dementia. And so they want to get earlier, is there prevention? Is there a trial that I can join? I'm having some memory problems, but I'm still working. In this case, this gentleman was actually working at the time when he was first started seeing his provider. And yet we don't give enough education and tool, really just the skill sets for our primary care providers to one, how do we diagnose mild cognitive impairment? And what are some of the workup that needs to be done? And what are some of the treatment? Because in this case, it probably was not a good idea for this person to be on Alzheimer's disease medication when this person really didn't have a diagnosis, clear-cut diagnosis. Another thing, there's a misunderstanding, really, in many cases that actually assumption that if you have something called mild cognitive impairment, although we have a lot of research focused on this, clinically, it's a very, very difficult concept for patients and actually for a lot of doctors to have. In this case, my patient really couldn't tell me what the diagnosis that he was given. And I would say that for the most part, when I get a referral for a patient with mild cognitive impairment, most of the times they would say, oh, no one gave me a diagnosis. I have no idea what I have because it's not dementia. It's not something that they're very familiar with. Assumption that all mild cognitive impairments are Alzheimer's disease, and that's a specialty clinic like such as ours. We're trying to kind of refine the diagnosis. So I would say that not having brain imaging is an extreme case. Most actually patients come with us with some brain imaging done, whether it's CT or MRI. And when I asked the patient and the wife, well, why didn't they do a brain imaging? They said, well, because, our provider said that it won't make any difference anyway in clinical management. So there's a, really misunderstanding about, what it is that we're working with. Another thing is that biomarkers in this case would be very helpful. And I would say that although it's been kind of the purview of the specialists like me in a memory clinic, I think what we really need to be braced for is really a lot of the blood biomarkers being available in the community. I get chats on my Epic message all the time. I have a patient in my clinic. They're asking me to order blood tests. And should I be ordering it? The new blood test for Alzheimer's disease. And I would say, well, I don't know who your patient is. It needs to be done very carefully. We can't just be ordering blood tests on somebody who may not even have objective, evidence of cognitive impairment. But the point is that the technology is advancing, the education is lagging. Another thing that I would, usually do at this point is broach the topic of driving evaluation, even though they have mild cognitive impairment, and also touch upon advanced care planning. So although they denied that there was any problem with driving, we actually ended up getting some records from the primary care provider, and it said that the wife had reported that her husband, who was still working at the time, was getting lost all the time while driving. So when I was just starting out as a junior faculty, that's one of the first things I did was discuss driving evaluation with my memory clinic patients, and scratching my head why no one came back to see me. So the point is that I quickly learned as a junior attending that some things are so sensitive that you really need to build a good rapport with your patient before you can broach, because it's a very sensitive topic, because one, the person who's being asked to take driving evaluation, it's the loss of losing a driver's license is just, as you can imagine, so devastating. But also, if you think about for the care partners, if your children are patients who have driving impairment, and if your parents, let's say, for example, lose driving evaluation, what does that mean for you? They would need ride for everything they do, everywhere they want to go, groceries, and we have no infrastructure to help our older adults when they are asked to basically give up their driver's license because they are impaired. So there's another problem. We do a lot of what's called dementia education. So our nurses are actually trained to go through what's called dementia needs assessment. And so they would meet separately from the doctor's visit to really go over point by point what are some of the things that they might be experiencing and they might need help. But we also discuss about what's coming up in the future, what you might be able to expect so that it's not a surprise. And I think it kind of speaks to what Dr. Borson was saying, is that, we need to be avoiding crisis. But sometimes it's not always, we have these programs, but it's not always easy to deliver because we have so much demand. Second case is a 72-year-old gentleman who came to see me in early Alzheimer's disease stage. He was 69. His wife was a full-time occupational therapist. And, she told me that, well, I just work part-time and, this is what I, hope to do. Fairly soon, in about, 6 months to a year, it became very obvious that he really needed full-time care. So she reluctantly resigned from her job, even though that was, in a way, her outlet for her. In a way, it was work, but it was her respite. And that's something that I see very frequently. And it usually tends to be women who resign from their careers or give up other things that they were doing, really because there's no one else to take care of their loved one. So that's something that we see, very, very frequently. I would say, early to middle stage is we actually also start seeing a lot of behavioral problems with dementia. And this is a very, very difficult stage for this gentleman. Every time his wife called me, she would whisper. And I would say, Mrs. So-and-so, can you talk louder? Because I can't hear. And she would say, well, my husband is so paranoid that every time I talk on the phone, he just comes right up to me and wants to know if I'm bad mouthing him. So I'm locked in a different room and I'm whispering for that reason. He followed her everywhere. She was exhausted. She started looking for a caregiver, and there weren't many caregivers who were willing to come in for a couple hours here and there. They wanted 4 hours, 8 hours, many times throughout the week. Another thing was that she looked for daycare. Now, she lives in a remote part of Maryland, and so daycares were very, very hard to find. And if you think about a lot of daycares, adult daycares, so one, my patients don't like them because when they go, they would say, yeah, there are a lot of old people there. And so, and they're not one of them. So also they lose insight. That's just part of dementia syndrome. So there's a lot of impaired people that they see, none of which problems, they have. So this is creating another problem. But also if you're, parents, can you imagine a child care where you can send somebody from 8 o'clock to 12 noon, but you have to pick them up at noon or right after lunch. And there's no after-hour care, so to speak. So that's what most of adult cares are. There are very little gap services after lunch or 2 o'clock, so that if you really wanted to keep a full-time job and still care for somebody because you have this backup system, there's this really, it's not sustainable. I think what they really need is a lot of respite. As I talk to you about the caregivers, of course, the financial resources are always a big problem, but I think they also need a lot of care coordination. Many people are very, very exhausted. They don't know where to go for help, whether it's website or even a book or, how do I know when I, log into care.com that this person would take a good care of my loved one. We just don't know these things, and it's a great need. As a matter of fact, this patient's wife, when I met her last time, which was 2 months ago, she said, you know what, I started my own support group at my church. There are 5 other people in this group. We do it every Wednesday, and they're asking me for another session because they find it, so useful. But she had to start her own to find, resources and help. The last case is a 92-year-old woman that I took care of while I was on medicine service. So I'm a geriatrician, I'm a memory clinic specialist, and I do a lot of research in Alzheimer's disease, but just for fun, I also do internal medicine hospital work. So this past 2 weeks, I was seeing, the youngest was 22 years of age, and the oldest was 93. So I see a broad spectrum of patients, so pneumonia, substance abuse, whatever that might be. But I had a 92-year-old woman who came in with delirium, so acute confusional state that happens a lot in older adults, and especially those with dementia. And I saw in my chart that actually she had been in the hospital 4 times in the past 4 months. Twice she was ruled out for stroke. She didn't have stroke, but she had mental status change, so they thought that she had stroke. And then I think it finally dawned on, the providers and the family that maybe this was all due to, underlying dementia. At least I think the provider recognized. So she was with me for 7 days total. 4 days she was delirious. And at home, what was actually happening was that one time, she's a very petite lady, but one time she actually threatened her children with a knife. She tried to, go out of the house, and a lot of just really behaviors that were completely out of character for the patient, according to the family. And I would see her children around the clock in the hospital, and every day her children would cry and say, I don't know why this is happening to our mom. And I saw also in her chart that she had actually been seen by one of the providers at our memory clinic, but just one time. And I said, well, your mom was diagnosed something called mild cognitive impairment. That makes her vulnerable for. And then I realized that what we hadn't done a good job was, here was a diagnosis I'm giving you. Once again, here are some of the things that you can expect. Here's a number that you can call, but the vulnerability and what that could mean in the future. And so I think those are kind of discussions that we probably should have had. And I would say this, case really illustrates hospital utilization escalates at the end of life. And so therefore, before that happens, once again, harkening back to many of the speakers had said, we need to be talking about advanced directives. And with mild cognitive impairment patients, I usually run into a lot of resistance. One is that because they hadn't been really approached about this topic before, they think that if I mention it, that means something bad. I'm seeing something bad in their in the patients, that maybe death is imminent. And I always have to say, no, this is something that I would like to discuss with all of my patients. That kind of puts them at ease. But also the message is always not correct. So when they think about advanced directives, they think of, is this like no CPR, no intubation? But it really should be about goals of care conversation. I can't tell you the number of times when, as a in-hospital physician, I've had the first goals of care conversation with somebody who was clearly had been terminal for many, many months, if not years. It had not been done in the primary care setting and not in the memory clinic setting or tertiary care setting. And I would say hospital is not the appropriate place. I do not have a personal relationship with the patient. I'm one of the 3 doctors, that's been rotating through. The family really has no one to trust. And so I would say definitely advanced care directives, which, really should take in the, as early as possible, I think would be great. And that's what we're really trying to strive to do. Thank you so much.
So as we can see, once you get into specialty care, it's hard to get an appointment, and they're just not there often enough. So our next presenter, Dr. Ian Neal, is online. So if we could switch over to get to his slides and have him visible. Dr. Neal, are you able to unmute?
Yes. Yeah. Can you all hear me?
Yeah, we hear you great. Give us a chance to get your slides up. Just a second.
Thank you very much.
I hope that everyone is really appreciating that it's a little different when you start thinking about over time living with dementia. We have concentrated a lot on diagnosis, and it is very, very important. And we appreciate the presentation this morning from Dr. Hodes and Walter about the emphasis on biomarkers and biomarkers beyond just Alzheimer's. But our focus really is on now that you have the diagnosis and you have to go from there for the rest of your lives. I appreciate Roberta really sharing her intimate story of the years that she lived with her mom with dementia, understanding that there was that period of time that she was able to go to memory care and give your family a break, understanding that there was that period of time that she ended up on hospice. And as Dr. O mentioned, from a specialty perspective, trying to help the patients understand beyond that crisis of diagnosis that this is just the beginning and that there'll be more. So I met Dr. Neal last fall, and he was talking to an audience of family medicine physicians. And I said, oh, you have the toolkit that needs to be spread more widely. So I asked him to come and present to this audience so that we would have an understanding of what tools are available, though they may not be as widely disseminated. So Dr. Neal.
Wonderful. Well, thank you all so much. And, it's an honor being able to speak with you all. And I apologize, I'm not able to be there with clinical duties. But, today specifically what we want to talk about is how to do all of this. That's the hard part that our primary care physicians have, is that we set up these tools that we can use to do cognitive assessment, but how can we actually fit it into our day-to-day lives? So again, I'm Dr. Ian Neal. I work at the UC San Diego School of Medicine as an associate clinical professor there, and I work in both our outpatient geriatric our outpatient memory disorders clinic, seeing patients for intake and assessment, as well as our inpatient senior behavioral health unit, where I see patients for managing advanced issues of dementia. I have no financial disclosures to report. Next slide. And I'm a member of a group called the San Diego Alzheimer's Project. And this is a state or a citywide consortium of doctors that meets as a roundtable to come up with ways to educate primary care physicians on how to better be equipped to take care of and evaluate patients with dementia. Because as we know, there's just not enough subspecialists out there. And so the County Board of Supervisors under Diane Jacobs funded this project to meet on a regular basis, and we've been meeting for about 8 years now to try to revise and improve ways in which we can do this. So we have guidelines that are available through our project specifically to help walk people through how to conduct a screening visit. And we can move on to the next slide, which also shows how to conduct a diagnostic visit. But the feedback that we often get when we present this to primary care physicians is, that's great, but I don't have time to do all of that because I've got a 15-minute appointment. How do I do it? And thanks to CMS, there is a way to do that now, and we can move on to the next slide. And that's through the Cognitive Assessment and Care Plan, which is a relatively new code. The next slide is perfect. 99483 that started in 2017 and is able to be used once every 6 months to assess patients who are on Medicare and see what is their diagnosis and be hopefully adequately reimbursed for that. The downside, as we heard in an earlier lecture, is that it's got very low utilization so far. A lot of it just due to lack of education of health systems on this. You know, we had heard about 3% nationwide are billing for the Cognitive Assessment and Care Plan. And so today I'm going to talk to you in very brief time about how to go through this, what it all entails. And I think the hope there is that it shows the gravity and the degree to which we really need to be assessing patients to come up with a diagnosis of dementia. And the reason for all of this is because we don't want to just do the diagnosis. You know, it's easy to just say, you know, we've done X, Y, or Z tests and you have dementia. It's hard to carry it on through the continuum. And that's the great thing that the Cognitive Assessment and Care Plan does, is it helps us figure out what to do with the diagnosis once it's been made. Next slide. So as you can see, it's a bit overwhelming. There are 10 different steps that are involved in the Cognitive Assessment and Care Plan, and all 10 of these things need to be done in order to properly bill and get reimbursed for it. The good thing is that this can be done over a period of about 3 months, so it doesn't all have to be done in a single visit. And we'll walk through systematically through each of these 10 steps, so we'll move to the next slide for the sake of time. The issue that I get from providers also with the Cognitive Assessment and Care Plan is they tell me this: you expect me to do all that in one visit? So as mentioned, it can be split up. And a lot of the elements that are involved here don't have to be done by the provider themselves. You can recruit members of your clinical team to really be able to help you. And this is, I think, getting back to the very beginnings of the talk today, is that it is all about the care team. And, you know, the days of the physician is the end-all be-all are gone. You know, we really do need to utilize the healthcare team to help take care of these patients. Next slide. So in terms of the 10 steps, the first is the basics. You know, we have to conduct a history and a physical exam of the patient. Interestingly, this is the one that often gives the hardest sticking points of the primary care providers, is that we just don't have enough time to do this. But, you know, if you don't have enough time to do a history and physical, maybe we need to start rethinking how to structure clinical appointments. And I think the good thing about the CACP is that you can allocate 40 to 60 minutes for this visit to do it. And it's got a decent enough reimbursement rate that it can account for that loss of funneling of patients. But what we need to do here is we need to do a detailed history of the patient, as well as do a neurologic exam and some form of cognitive test, be it the MoCA, the MMSE, the SLUMS, etc. Next slide. The second step in this is that we have to be able to document our medical decision making. This is a bit of an easier one in that, you know, it doesn't require a lot of time, but providers do need to know that if they're not billing for a moderate to high level of complexity, it won't count for the Cognitive Assessment and Care Plan. So they do just need to follow those E&M guidelines for moderate to high level complexity of care. Next slide. The third step is that they have to do a functional assessment of the patient, assessing their activities of daily living, instrumental activities of daily living, as well as making a clinical judgment on their medical decision making. And so we highlight all of those here. And this is, I think, as a geriatrician, the part that's most important, is that this is what it's all about. You know, it matters less what your cognitive diagnosis is. It matters how you're functioning with that cognitive diagnosis. And so, you know, assessing that is essential and something that has to be entailed. And so thankfully it was included as one of the cornerstones of this code. Next slide. Beyond that, we also have to have some type of formal staging of dementia involved. Oftentimes what's recommended there is to use the FAST scale, a 1 to 7 point scale of how functional you are with regard to your cognitive decline. The downside to most of these scales is that while they can help kind of get us a sense of where somebody is on their continuum, not all of them are perfect. The FAST scale alone, for instance, we see is not as great at predicting longevity as we would hope it would be. But it also really highlights what patients can't do. So while it's not necessarily involved in the formal staging, we often do recommend doing something to assess what patients can do as well. And there's a useful tool here called the TIPA-SNO GIMS model that can be utilized to really look at what patients can do with regard to their cognition and how we can act on that and use that to help better engage with the patients. So whenever I think about staging, I think about both the FAST, but also something like the GIMS model to see what they can do. Next slide. This is that GIMS model, and as you can see, it highlights kind of the basic characteristics of what patients can do at each stage, but then also things that may interest them. So it's really useful from a standpoint of intervening with patients to be able to highlight, hey, you're great at this task, so here are some tasks that we can do to help, to focus on improving cognition, to focus on keeping you behaviorally calm and redirectable, et cetera. So this is a kind of useful model that exists beyond just staging for staging's sake to actually be able to help patients and their caregivers interact with the patients. So something else to think about in the staging section. Next slide. Probably the thing that I spend the most time on when I'm doing my cognitive assessments is the reconciling of high-risk medications. There's nothing outlined in the CACP in terms of how this is done, but it's important that we do this at every interaction with the patient, that we assess their medications and see what could potentially be removed here. Is there anything that's not necessary any longer? And when we're thinking about cognition, using something like the anticholinergic burden index, which is displayed here, is often a nice way for primary care providers to think about the lowest hanging fruit of the most cognitively detrimental medications and how can we remove those in a systematic way to try to help with the patients. So these are drugs that block acetylcholine, and if they do that, they're blocking the hippocampus in the brain from functioning properly and increase the risk of delirium, have a higher incidence of rates of cognitive decline. And there's a lot of meds that have anticholinergic action that we don't necessarily think of as anticholinergic. And so doing what we can to substitute, replace, or minimize additions to drugs, especially if somebody needs to be on some of these, can often be really helpful. So this is something that we think about when we're doing this stage 5 of the CACP. Next slide. Additionally, we have to have some type of evaluation of neuropsychiatric and behavioral symptoms. There are tools that are built in to try to help with this, such as the NPI-Q tests, the PHQ-9, or the geriatric depression scale. It's not as well specified exactly what tool you use, but you have to use some kind of formal tool to actually assess to see, do the patients have any neuropsychiatric or behavioral symptoms in order to utilize this tool, utilize this code. Next slide. Additionally, we have to evaluate the patient's safety. And so there are lots of things that we have to screen for with safety with cognition. And the hope with the cognitive assessment and care plan is that it can help kind of systematize this for providers so that we make sure that we're addressing the things that are the most detrimental, assessing if the patient is still driving. Are they taking their medications? And if so, are they taking them as prescribed? What is their method of doing that? Are there concerns about safety in the home? Has the patient gotten lost in familiar places? Are there firearms in the home? If there are they accessible? Does the patient know the code? Is the ammo stored in the gun or is it stored elsewhere? Removing firearms from the home if there's concerns. Those are all essential things we need to talk about. Assessing risk of falls, assessing who lives with them. These are all things we typically do regularly as a geriatrician, but in the primary care, we may not necessarily have the time to, but these are the things that really matter to the patients and matter to the patient's both longevity and quality of life. And so assessing for these things is very important. Next. The 8th step in the CACP is to identify social supports, determining how much caregivers actually know about the disease process, how much they're willing to provide care, and if they aren't, who is going to give care in the interim. And so this is something that we can actually pair, for instance, with step 7 of, identifying, hey, if the patient is living alone, we need to get something in place to help make sure that we're looking out for them. Maybe utilize home health agencies to be able to get some in-home nursing support or in-home behavioral health nursing support if there are behavioral symptoms, to be able to better take care of the patient and keep them safe in their homes. And so identifying that, creating an action plan for that, and documenting it is needed for this code. Next. There are a lot of caregiver resources out there to try to help with this, but the problem that I find a lot of patients and providers have is that there's just so much, but we don't know where to even start looking for it. We do have some of that information available through our group, the Alzheimer's Project, at our website here, championsforhealth.org/Alzheimer's. But of course, knowing your local community resources is essential here too. There's a lot to know. So this is why the care team is so important. And the hope is that we can start seeing more and more social workers embedded into primary care offices to try to help with this. I always say at our memory disorders clinic, our social worker is the most important member of our team and is the one that really is there day to day, helping the families out with connection with these processes. And if you don't have that, you're going to be struggling. Unfortunately, a lot of health systems aren't providing social workers in the primary care offices because it's costly. So then finding outside care groups can potentially help offset that, but it's a matter of searching and determining what is available in your area. Next slide. The 9th step is that we have to document all of this. We have to develop, first we have to develop an advanced care plan, make sure that we know kind of what's going to happen next. Do you have power of attorney in place? Have you discussed wishes for end of life, et cetera? Doing this at the start is important because that way we get the patient's understanding while they still have capacity. Again, not once we've reached that crisis care point, as was mentioned earlier, when the patient may lack capacity and is having behavioral agitation. Intervening here is important. And so that's why I was glad this was included as a step in the CACP. Next slide. And then the 10th is finally, once we've done all of this, compiling it all into a written care plan, putting your progress note together, detailing everything that's been talked about, making sure that we're documenting each of the points of the CACP having been done and evaluated. And then once you've done that, then you're able to bill and code for the CACP and hopefully provide the patient with better care as a result. But again, the issue is now getting patients to, or getting providers to know about this and helping work with them to integrate this in their workflows. So that's something that we're working on with the Alzheimer's Project and with work through UC San Diego at the moment, is how to actually integrate it in a seamless way and get it done. But it's a slow and uphill process, as one can see by the fact that this tool has been out there since 2017 and we're still only at 3% utilization. Next slide. We could skip over this one for the sake of time. This is just an example of what a written thing looks like. But next slide. One element that's important in the safety section is to know that we do have to disclose a diagnosis of driving, and it varies state by state what we actually have to do. But this is something that does have to be integrated as part of the CACP, is knowing your state laws and determining when to report for driving, and if it's to the DMV, to the Department of Public Health, or other. Next slide. The thing that often gets missed in this, again, because here we are talking about billing and how do we fit it into our work time, is the need for empathy, is that these are difficult diagnoses to have. We really do need to be allocating this time to listen. And this is another reason why I think the CACP is important, is that it does allocate extra time for the visit. And, doing that instead of trying to group all of this into a 20-minute follow-up appointment gives us and gives the providers the opportunity to truly sit there and take that time to listen to the patient, show empathy with the caregivers, and to start to help them understand how things are going to go down the road. And so that's, I think, the real silver lining here with this, is that it gives us extra time and permission to have some empathy. Next slide. It's also important to note that it doesn't begin and end with the CACP. These discussion of resources, for instance, this is the thing that happens longitudinally over time. And, we want to be repeating this serially throughout our relationship with the patients, because, most of the time what the patient is going to take away from that initial visit is just, you have dementia. They're not going to remember anything else. So writing it all down, having these conversations, reminding patients about it at follow-up visits is also important. But this is a way to kind of start the relationship, start the discussion with the patients. Next slide. Again, this is to mention that there are just a lot of resources out there, but trying to find ways in which to understand and know what your community has is essential. Next slide. And with that, I will end it here. Again, we have only a few minutes to discuss this, unfortunately, but there's a lot more to come. So again, if you go to our website, you can learn more information about this. We do also have webinars available for primary care providers free of charge for CME to specifically learn more about all these different steps of cognitive assessment and processes. And I think the Alzheimer's Project has really been something that we found has been helpful throughout San Diego to try to help improve primary care providers' understanding and willingness to engage in things like this. And so when we're thinking about how to integrate the cognitive assessment and care plan, having some type of regional, local government support to do provider education is, I think, essential. And I hope that our project can serve as a model of ways in which this can be done and done successfully. And with that, I'll end it there and get you out right about lunchtime.
Thank you, Dr. Neal.
Thank you.
This morning has been very interesting. We started out really understanding the plight of the family living through dementia. And we learned how most of the people with dementia have many chronic conditions before they're diagnosed, but they're diagnosed in a crisis situation, which we really want to get rid of those crises. We saw that a person with dementia lives years, and there are episodes of crisis that they go through with their family. We see that there's not enough specialists to help guide us through this for various reasons. But it is important that when they do see the specialist, they begin to have some of that anticipatory guidance. I like in Dr. Neal's presentation that you kind of set up that there are those resources there. You've set up how this could be a team-based approach to doing comprehensive care. But the reality is it's just not happening because it takes a system change. The way we usually approach things is we come up with these tools and we tell the physicians about it and say, go do it. That does not make change. It has to be a system change. System change is helping with support. It's more than just reimbursement, because the CACP is further reimbursement, but that's just really not enough. I want to highlight one thing that Dr. Neal mentioned, which is we as geriatricians already do. Medication review every visit. Medication review every visit. And that's not what's done in primary care. It's so many things that we do as geriatricians, and to be in this room with so many is rare, really rare. But we really do think about what matters most to the patient. They have all these chronic conditions. It's not just the one thing that's going on with them. And so as we begin to go further into the afternoon, after we have our lunch, we're going to come back and look at these other health systems beyond primary care that one living their life with dementia and their care partner is having to experience. And then in the end, of the day, we'll have some good suggestions of some care coordination. But as we go through the day, and especially those of you on the panel, think about the recommendations that we need to make that'll help improve the systems, the health systems. So with that, we're going to stop and break for lunch and come back together at 1:45 promptly. Thank you.
Produced by the U.S. Department of Health and Human Services.